Welcome to the deep dive. You're here, I imagine, because you want to really get a solid handle on pancreatitis.
hmm
Think of this as your express route, your focused look at this really key condition.
Yeah, absolutely.
We're talking inflammation of the pancreas. You know, that organ doing vital work, digestive enzymes, insulin, pretty important stuff.
It really is. And we're basing this deep dive on your revision notes for pancreatitis. The plan is simple. Pull out all the essential high-yield information you actually need for revision.
Right.
Everything from the definition, causes, right through to management. And we'll sprinkle in some memory aids, maybe some example questions to help it stick.
Okay, sounds good. Let's dive straight in then. Pancreatitis, inflammation of the pancreas, we've got that. But it's not just one thing, is it? There are different types.
Exactly. Two main types to distinguish. First, you've got acute pancreatitis. That's a sudden onset, a real flare-up of inflammation.
And an attack.
Pretty much, yeah. An abrupt attack on the pancreas. Then the other side is chronic pancreatitis. This is more long-term, persistent inflammation.
And that sounds like it causes lasting problems.
Unfortunately, yes. It can lead to permanent damage over time. Often means patients end up needing enzyme supplements just to digest food properly. And sometimes, down the line, even surgery might be necessary.
Okay, so acute versus chronic. What actually triggers this inflammation? What are the common culprits behind pancreatitis?
Well, there's quite a range of potential causes. Gallstones are very high up the list.
Right.
And so is excessive alcohol use. That's a big one.
Okay.
Then you've got certain medications that can trigger it, high levels of triglycerides, fats in the blood. Infections can play a role, autoimmune conditions.
Where the body attacks itself.
Exactly. Genetic factors, too, like in cystic fibrosis. And sometimes it's down to anatomical issues, like abnormalities in the pancreas or the ducts.
Wow. Okay. That's a lot to remember. Is it a trick, a way
Yeah.
to keep those causes straight?
There is. Mnemonics are great for this. A really popular one is I get smashed.
I get smashed. Okay, break that down for us.
Sure. So I is for idiopathic, meaning sometimes we just don't pin down the exact cause.
Okay.
G, gallstones.
E.
A, ethanol, so alcohol. T is for trauma. S is steroids. M is mumps and other infections.
Okay.
A is autoimmune diseases. S is scorpion sting, less common here in the UK, obviously, but good to know.
Yeah.
8 stands for hypercalcaemia or hyperlipidaemia, high calcium or fats. E is for ERCP.
That procedure.
Yeah, the endoscopic retrograde telangioppancreatography.
Yeah.
It's a procedure on the bile and pancreatic ducts that can, although rarely, trigger inflammation itself. And finally, D is for drugs, other medications besides steroids.
I get smashed. Got it. That's genuinely helpful. Now, thinking about causes versus risk factors, are they basically the same list, or is there a difference?
There's a huge overlap, definitely.
Yeah.
But it is useful to specifically think about the main risk factors, the things that just increase your chances of getting it.
Right.
So again, gallstones and excessive alcohol consumption are right at the top. Major risks.
Makes sense.
Then obesity and smoking are also key factors that up your risk. Certain medications, having a family history of pancreatitis, those high triglyceride levels we mentioned, infections, trauma, underlying autoimmune diseases, all these make someone more susceptible.
Okay. Let's put that into context. Imagine a middle-aged patient comes in, severe abdominal pain, they smoke, they're obese, and maybe they drink, say, moderately a couple of glasses of wine a few times a week. Which of those is the most significant risk factor for acute pancreatitis? Smoking, obesity, or the alcohol?
That's a good practical question. So while smoking and obesity are definitely risk factors for health problems, and they can worsen the outcome of pancreatitis,
Right.
the most direct and significant risk factor for actually triggering acute pancreatitis from that list, even if the alcohol is described as moderate, is likely the alcohol itself. Well, the term moderate can be subjective, but alcohol has direct toxic effects on the pancreas. Compared to smoking or obesity as a primary trigger, the cumulative effect of alcohol, even in amounts that might seem moderate to the patient, often carries more weight for acute pancreatitis specifically. It really highlights that excessive is key, but even regular intake can be problematic for some.
Okay, that's a really important distinction. So we know the triggers, the risks. What is actually happening inside the pancreas? What's the mechanism?
Fundamental issue, the thing you really need to grasp, is this: premature activation of digestive enzymes inside the pancreas.
Okay. Before they're supposed to activate.
Exactly. Normally, these enzymes are made in an inactive form. They only switch on when they reach the small intestine to break down food. In pancreatitis, something causes them to activate too early while they're still in the pancreatic tissue.
And that sounds bad. What happens then?
It kicks off a cascade. This early activation leads directly to inflammation and damage to the pancreatic cells and tissues. It's like,
Yeah.
well, it also triggers the release of other toxic substances right there in the pancreas, which can then leak out and affect the whole body.
So it's almost like the pancreas starts to digest itself, using its own tools against itself.
That's a very good way to think about it, actually.
Yeah.
A clear and accurate analogy. The pancreas's own powerful digestive machinery turns inward and causes self-inflicted damage.
Oof, grim picture indeed. Now, someone presents with that classic severe abdominal pain. How do you tell pancreatitis apart from other things? What else is on the list, the differential diagnosis?
Yeah, differentiating is critical. Several conditions can definitely mimic pancreatitis symptoms. You need to consider things like peptic ulcers, gallbladder issues like cholecystitis or biliary colic.
Right, gallbladder pain can be similar.
Very similar sometimes. Also, more serious things like gastrointestinal cancers need to be ruled out. And then other GI disorders causing pain, or even just a really severe bout of gastroenteritis.
So always keep those differentials in mind. Don't just assume pancreatitis with belly pain. Okay, let's zoom out a bit. Here in the UK, how common actually is pancreatitis? What's the epidemiology look like?
Looking at the UK data, the annual incidence is estimated around 15 to 30 cases per 100,000 people each year.
Okay, 15 to 30 per 100,000. And are there particular groups it affects more?
Well, it affects people of all genders,
Mm,
but it does seem to be more prevalent in middle-aged and older adults.
got it. So we know roughly who gets it and how often. Let's get really practical now. What does acute pancreatitis look like? What are the key signs and symptoms that should make you suspect it?
Okay, the clinical picture of acute pancreatitis can be quite stark. The number one symptom, usually severe, is that abdominal pain, typically upper abdomen.
Epigastric.
Epigastric, yes. And very often, patients will say it radiates and goes straight through to their back.
Right, that back pain is key.
It is. Nausea and vomiting are also extremely common.
Yeah.
You might see a fever, a rapid pulse rate, tachycardia, and when you examine the abdomen, it might be swollen and very tender. Sometimes you can even see jaundice, that yellowing of the skin and eyes, and just general digestive upset too.
And what about specific findings on physical examination? What should you look for?
So on exam, you'll often find that epigastric tenderness we mentioned, maybe with guarding the muscles tensing up when you palpate.
Okay.
Then there are those two classic, though maybe less common signs. Gray-Turner sign, that's bruising on the flanks, the sides.
Right.
And Cullen's sign, bruising around the umbilicus, the belly button. The memory tip for Cullen's is easy. Cullen's around the belly button.
Nice, simple.
Also look for signs of dehydration, dry mucous membranes, coarse skin turgor, because patients can lose a lot of fluid internally and through vomiting.
Definitely important signs to remember. Okay, another scenario. Patient comes in, severe upper abdominal pain radiating to the back. You examine them and notice bruising around the belly button. Now, which finding most strongly supports acute pancreatitis? Rebound tenderness, that periumbilical bruising you just saw, or just decreased bowel sounds?
Well, based on what we just discussed, the periumbilical bruising Cullen sign is the most specific indicator of pancreatitis among those options in that context.
Makes sense.
Rebound tenderness suggests peritoneal irritation, which can happen in pancreatitis, but also other things. And decreased bowel sounds are pretty non-specific in abdominal emergencies. So Cullen's sign really points towards it here.
Okay, great. So we have the clinical picture, the signs. How do we actually confirm the diagnosis? What tests are essential?
Right, so diagnosing acute pancreatitis typically relies on meeting 2 out of 3 specific criteria.
2 out of 3. What are they?
First, the typical clinical presentation, the symptoms and signs we've just gone over. Second, you need significantly elevated serum amylase, or ideally, lipase levels. Usually more than 3 times the upper limit of normal is the threshold.
Okay.
And third, characteristic findings on imaging, most often a CT scan of the abdomen showing pancreatic inflammation or changes.
So those blood tests, amylase and lipase, they're really crucial then.
Absolutely fundamental. Lipase is often preferred nowadays. It tends to be a bit more specific to the pancreas, and its levels usually stay elevated for longer than amylase, which can sometimes return to normal fairly quickly.
Good point. And imaging. You mentioned CT. What's the role there?
Imaging is vital, not just for diagnosis confirmation if the bloods aren't definitive, but also really important for assessing how severe the pancreatitis is, looking for complications like necrosis, dead tissue, or fluid collections.
What about ultrasound? Is that used?
Yes, ultrasound is often the first imaging test done. Its main strength is looking for gallstones, since they're such a common cause. It's quick, non-invasive. But for actually visualizing the pancreas itself and the extent of damage, especially in moderate to severe cases, a contrast-enhanced CT scan is generally the go-to.
Okay. Now, how does diagnosing chronic pancreatitis differ? Is it the same criteria?
No, it's a bit different. For chronic pancreatitis, the diagnosis leans more heavily on the clinical history, maybe recurrent attacks of pain, symptoms of pancreatic insufficiency like fatty stools, weight loss, or developing diabetes.
Right, the long-term effects.
Exactly. Combined with imaging that shows evidence of permanent structural damage to the pancreas. Things like calcifications, scarring, or changes in the pancreatic ducts.
And are there other specific tests used for chronic pancreatitis?
Yeah, besides lipase and amylase,
Yeah.
which actually might not be that high in chronic disease because the pancreas is so damaged, we'd look at a full blood count, kidney function, UNEs, glucose for diabetes screening, liver function tests, and then more advanced imaging is often needed. MRI, especially something called secretin-enhanced MRCP, gives really detailed views of the ducts. Endoscopic ultrasound, EUS, is also very sensitive for picking up subtle chronic changes.
Right, more detailed imaging needed there. Okay, so we've covered diagnosis for both acute and chronic. Let's move on to management. What are the general principles?
Okay, the core principles for managing pancreatitis, whether it's acute or chronic, really revolve around supportive care. That means good pain relief, managing fluids with IVs if needed, making sure nutritional needs are met, and this is key, identifying and addressing the underlying cause whenever possible.
Let's break down acute pancreatitis management first. It sounds like an emergency.
It absolutely is. Acute pancreatitis often needs immediate hospital admission. The first priority is usually aggressive IV fluid resuscitation. These patients can lose a lot of fluid into their tissues and from vomiting, so replacing that fluid quickly is critical.
Okay, fluids first. What else?
Pain control. The pain can be incredibly severe, so effective analgesia is essential. Opioids are often required.
And antibiotics, do they get those routinely?
That's a point of discussion. Current NICE guidelines actually advise against routine prophylactic antibiotics, meaning giving them just in case.
Okay.
They're generally only used if there's clear evidence of an infection, like infected necrosis confirmed on imaging or by sampling.
Right. What about blood sugar? You mentioned insulin earlier.
Yeah, pancreatitis can affect insulin production, so blood glucose needs close monitoring. If the patient develops hyperglycemia, they might need insulin treatment, at least temporarily.
And feeding. Do you starve them?
The approach has evolved. Initially, if someone's got severe pain, nausea, vomiting, they'll likely be kept nil by mouth. But as soon as they start to improve, the aim is to reintroduce feeding, usually starting with a soft, low-fat diet.
What if they can't tolerate eating for a while?
In more severe cases, or if oral intake isn't possible for several days, we need to provide nutritional support. Enteral feeding via tube is preferred over intravenous nutrition if the gut is working. This might be via a nasogastric tube, an NG tube into the stomach, or sometimes a nasojejunal tube, an NJ tube that goes past the stomach into the jejunum.
Why the NJ tube sometimes?
The idea is that placing the feed further down the gut might stimulate the pancreas less, which could be beneficial in severe pancreatitis.
Okay. What else are you watching out for in acute pancreatitis?
Complications are a major concern. We need to be really vigilant for systemic complications, like ARDS, acute respiratory distress syndrome, or DIC, a clotting disorder, and local complications like infection developing in the pancreas or fluid collections or pancreatic necrosis. There are scoring systems, too, like Apache 2 or the Glasgow score, which use clinical and lab data to help assess severity and predict risk.
Right. Those scoring systems help gauge how sick the patient is. Is surgery ever needed in the acute setting?
Sometimes, yes. If an abscess forms or if there's infected necrotic tissue that needs removing, surgery or increasingly minimally invasive drainage procedures might be necessary. Large symptomatic pseudocysts, those fluid collections might also need draining, often guided by radiology. And importantly, if the pancreatitis was caused by gallstones and it was a mild attack, removing the gallbladder, a cholecystectomy is usually recommended, often during the same hospital stay or soon after, to prevent it from happening again.
Okay, that covers acute management well. Now, shifting gears to chronic pancreatitis, how does that management differ?
The focus changes, right? Definitely. With chronic pancreatitis, the priorities shift. Long-term pain management becomes a really central and often difficult aspect of care. Patients can have persistent, debilitating pain.
Yeah, that sounds tough.
It is. Another cornerstone is pancreatic enzyme replacement therapy, PERT. Because the pancreas is permanently damaged, it doesn't make enough digestive enzymes, so patients need to take enzyme capsules with meals to digest food, especially fats, and absorb nutrients properly.
So replacing what the pancreas can't do anymore.
Exactly. And lifestyle advice is absolutely crucial. Stopping alcohol completely, quitting smoking, these are vital to try and slow down the disease progression and manage symptoms. Then it's about ongoing monitoring, checking for that exocrine insufficiency we treat with PERT, and also endocrine insufficiency, meaning diabetes, which is common, and regular surveillance for complications.
Okay. So thinking about the long term, what's the prognosis generally like for pancreatitis?
It really varies hugely. Depends on whether it's acute or chronic, the severity of the initial attack if it was acute, and whether complications develop. Most people with mild acute pancreatitis recover fully, often within a week or so.
That's good.
But severe acute pancreatitis, especially with necrosis or organ failure, has a much more guarded prognosis. Mortality rates can be significant in those cases. Chronic pancreatitis is, by definition, progressive. While management aims to control symptoms and maintain quality of life, it can lead to significant long-term issues and potentially shorten lifespan for some.
And what are the main complications we need to be aware of, both short and long term?
Key complications include pancreatic necrosis tissue death, infection, either the necrotic tissue or fluid collections, pseudocysts forming, and severe systemic complications like organ failure, lungs, kidneys, cardiovascular system.
Yeah.
In chronic pancreatitis, you worry about diabetes, malabsorption causing weight loss and nutritional deficiencies, chronic pain, and also an increased long-term risk of developing pancreatic cancer.
Right. That really underscores how serious this condition can be. Okay, let's try and pull this all together. For someone revising, what are the absolute must-know takeaways about pancreatitis?
Okay, key points. Remember, pancreatitis is inflammation of the pancreas. Know what the pancreas does? Enzymes, insulin. Know the top causes gallstones, alcohol, and maybe keep that I get smashed mnemonic in your back pocket. Recognize the classic acute presentation. Severe epigastric pain radiating to the back, nausea, vomiting. Remember the signs like Cullen's and Gray Turner's. Understand the diagnosis, 2 out of 3 criteria, clinical lipoceme LAs, 3x normal, CT findings.
Got it.
And grasp the management principles. Supportive care, fluids, pain relief, nutrition, and treat the cause in acute. For chronic, focus on pain, enzyme replacement, PE rate, lifestyle changes, and monitoring for complications like diabetes and malabsorption, and always be thinking about potential complications.
That's a fantastic summary. It's a complex topic, but hopefully breaking it down like this has given you a really clear high-yield framework for your revision.
Definitely. And as always, we really encourage you to go beyond this, do your own further reading, and crucially, test yourself with practice questions to solidify your understanding.
Absolutely. And a final thought to leave you with. Consider the profound long-term impact chronic pancreatitis can have on a patient's daily life and the ongoing challenges clinicians face in managing this complex, often painful condition effectively.
Yeah, definitely something to reflect on. And for those of you preparing specifically for the MSRA, remember passthemsra.com and the free resources at freemsra.com are there to help you.
Great resources. Thanks for joining us on this deep dive today. We'll catch you on the next one.